things. But to our surprise, it was a case of pyogenic granuloma again. So these are my differences. I have some spotters that we will show subsequently. So I'll call Dr. Anirban Bhaduri from Shrutai Foundation. Anirban Bhaduri is a great oculoplastic surgeon in West Bengal.
Thank you. Good morning, everybody. And it's nice to have an audience of doctors who are interested in eyelid tumors. So what we are going to do you've already seen pictures which you're going to see again and again because we want to drive in the point. We actually learn by repetition. And it's all about pattern recognition. So this is what we're going to try to emphasize during the time of this course. Okay, the thing is that what is good and what is bad? I mean, you've seen these pictures before. Dr. Shipurna has shown them. Chandana madam has shown them. And so which of these you think is good and which of these are bad? There are 4 pictures to choose from. You can speak out loud. Second and the fourth, you're faculty, you're not allowed to speak. Anybody else? You can all come forward. This is a very informal meeting. So 4 pictures, which of them do you think are good and which of them are bad? Speak out loud. Okay. Yes. The other thing is now tell me why are these good and why are these bad? Okay. You know what? We should exchange places. Because exactly, that is what it is about. So one of the hallmarks is loss of lashes. See, what happens with malignant tumors is they attack the hair follicles and destroy them. So that leads to loss of lashes. If you see the picture here, you have the diagnosis. It's a lid margin lesion. There is hardly any pigmentation and there is distortion of lashes. So there are hypertrophic lashes growing in abnormal directions, but there is no loss of lashes. This is a classic marginal nevus. Okay? As opposed to these situations where there is loss of lashes. So that is the first point. Sorry. Okay, then you have abnormal blood vessels. So benign lesions do not have abnormal blood vessels on the surface. They would have normal blood vessels or prominent blood vessels just because they've been pushed forwards, right? As you already pointed out, ulceration. Very good point. Okay. And then, of course, your first point, which was thickening or the distortion of the eyelid margins. So that is what you see in all these lesions. Now, suppose you had a basal cell carcinoma here. That would not cause destruction of the lid margin. It would not cause vision loss, loss of lashes. But then what else would help you to diagnose? We'll keep coming across that. So these are again benign lesions. You've been seeing benign lesions. These are all cystic lesions of the eyelid. Okay. So they may or may not transilluminate. So this one, for example, pilar cyst or a sebaceous cyst is not going to transilluminate because the content is sebaceous material. This is not going to transilluminate. Okay, but the others may. This, madam has already shown tarsal cyst. Tarsal cyst is something that is often confused as a chalazion and are often operated as a chalazion and they always come back. Okay, these are lesions that you need to excise from the anterior surface. And they always have a footprint on the tarsal plate. You might have to sacrifice a part of that tarsal plate. Okay. Now we'll come to solid masses. You've again been seeing these masses. Okay. What is this? Okay, let's start with the first one. What is this? Madam described it. Cerebriform surface. Sometimes they're very dirty looking, stuck on. So this is the seborrheic keratosis. It's called cerebriform because it looks like the kernel of a walnut or your brain, right? This, what is this? This is a child. Multiple lesions. Yes, this is also molluscum. So molluscum classically is described as having an umbilication, but it does not happen in the early phase. Okay. And what is important is the redness of the eye. You will find follicular conjunctivitis. Okay. You need to excise these, otherwise that conjunctivitis is not going to resolve. All right. This is very simple. Sputter. Cavernous hemangioma. This again is a nevus. Okay. Just because they're not pigmented does not mean that they are not nevi. This one had me stumped. I actually went ahead and did an incisional biopsy for this. Can you guess what it is? It's a chalazion. Yeah, it's the size that confounds you, but it's a chalazion. And this dirty, ugly looking thing here is again a seborrheic keratosis. But in all of these things, if I lift up that lesion, you will find that it's pedunculated. The lid margin is not affected. Okay, so none of these is the lid margin damaged or destroyed. The other thing is, what is the commonest eyelid malignancy? Basal cell carcinoma, right? Where did you read that? No, wait. This is important. Where did you read that? Because that's exactly what all of us read and grew up with. Basal cell carcinoma is around 90% of all eyelid malignancies. But that is Western literature. Okay, what is the second most common malignancy? The second most common malignancy in the West is actually squamous cell carcinoma. Sebaceous gland carcinoma is a rare tumor. Now these are a selection of studies from India. These are all hospital-based case series, and you will find that basal cell carcinoma and sebaceous gland carcinoma are neck and neck. In some, you will find that sebaceous gland carcinoma is actually slightly higher. In others, you will find that basal cell carcinoma and sebaceous gland carcinoma are actually almost the same. So that is the scenario in India. Okay, basal cell carcinoma is less common in our country as compared to sebaceous gland carcinoma in the West. Okay, squamous cell carcinomas are again very rare in India. In all of these series. But if you look at statistics from further north, so if you look at Nepal, you would find in the higher reaches, squamous cell carcinoma again gains prominence. Okay. Okay. This is all stuff that you know. We are just revising. Look at this lesion. Part of it is pigmented, part of it is not. It's got a nice, smooth, shining surface. Right? Yes? I again request you, please come forward. We can interact better. And please don't be afraid of making mistakes. That is the entire point of an instruction course, because we want all of us to learn from each other. Okay? So what do you think is this? There is pigmentation. Okay, look at the eyelashes. Therefore, so you made the diagnosis. Therefore, it is a BCC, right? Okay. This is another one. Ulceration and the margins. Indurated, rolled out margins. So you're right. This is also a basal cell carcinoma. So the others are all going to be basal cell carcinomas. This is what we see. Again, a nodular ulcerative lesion here. Okay. With pigmentation. Pigmentation is actually fairly common in basal cell carcinoma among our population. Now this is a variant of basal cell carcinoma. Okay, this is the morphia form or the sclerosing type of basal cell carcinoma. This is a problem. See, I have marked out the margins. This is a 4 millimeter margin that's been marked out for excision. Here, you really don't know how far this tumor extends in the deeper tissues. All right, how much time do I have left?
1 minute.
1 minute, okay. Rush. Okay. Diagnosis. Will this make it easier? So it's a lesion which is mostly in the inside of the eyelid. It has a nodular component and it's got a flat component. Okay. What is the color? Like a basal cell carcinoma. Yes or no? Look at the color. This is also mostly nodular, little bit of ulceration arising from the lateral canthus. So look at the color. The color is important. The yellow tells you that there is oil, okay, or fat. And these are all sebaceous gland carcinomas. And they can be as extensive as this. Both the upper and the lower lids involved. The entire conjunctival surface is involved. There are yellow nodules all across. And this is one variant, which is only the pagetoid or diffuse variant, where you do not have any mass lesion. You can have keratin present on the surface. These patients often present as a unilateral blepharoconjunctivitis. So any time you see a unilateral blepharoconjunctivitis which has been treated by our colleagues with topical steroids, with ointments, always do a biopsy. Okay, these are sebaceous gland carcinomas in disguise. This is the rarer of the tumors in India. Squamous cell carcinomas, typically described as having redness and scaling. There can be fissuring and ulceration, but they don't look like the basal cell carcinomas, right? This was an adenosquamous carcinoma, which is a variant of squamous cell carcinoma, very aggressive tumor. And this is what? Volcano-like lesion, central crater. That's a keratocanthoma. Okay. Now, keratocanthoma can actually be a squamous cell carcinoma in disguise. So always biopsy them and then treat accordingly. Thank you. I'll stop here.